Hello, I'm Craig Stern. We've been talking about drug cost and about drug utilization. And if you recall, we talked about utilization as being the multiplier, so that an individual cost of a drug multiplied by the number of prescriptions that a person has gives an idea of how much drugs cost. The question that could be asked is, well, if utilization is the multiplier and it can make numbers go up really fast, how do you go about managing that? What is the appropriate way of doing it so that we're sure that you've got appropriate use of medications, not inappropriate use, and that all of the medications that should be given are given, and yet the medications that shouldn't be given or are causing problems are in fact removed? Well, there are many ways of doing that. One is to use prior authorizations, where you're asking for the medication to be identified by criteria, clinical criteria, to ensure the fact that it is being used in the right population, in the right way, for the right duration. A second way of doing this is to take a look at it from utilization. So do utilization review. Look for those drugs that are making the biggest impact and try and determine whether they are being used correctly. Other options are to use quantity limits or to try and limit the size of a prescription based on how it should be used, so that in fact you're limiting prescriptions and they can't be inappropriately increased more than what someone would use. You could also use other kinds of limits. So you could use limits with regard to maximum dollar amounts, use that as a trigger to identify those particular medications that have the biggest impact. You could also use issues with regard to refill limits, so that medications like, for example, antibiotics are not inappropriately used so that you're using them too much. The question then is if you use these techniques, how effective are they? And that's really where there's a general discussion. For example, if you take a look at prior authorizations, there haven't been that many studies done, but there has been a few studies done, one at the University of Oklahoma, and what in general what's found is that across the country approximately 80 to 85% of all prior authorizations are approved. Well, if they're approved, then the question is, that indicates that maybe they're used correctly, but you're also adding a lot of noise or a lot of problems into the system that causes more time and trouble for physicians. In addition, if you take a look at other edits, you see that they may limit the size, but in fact the quantity of prescriptions, the number of prescriptions continues to go up. So there is a question as to whether these particular techniques, these tools actually work, and there haven't been a significant number of studies in order to determine what the actual benefit is of these particular elements. So let me point out to you that it is necessary to deal with drug cost when we're looking at a benefit. It is necessary to look at utilization, and that we have particular tools for it. But it may be that those tools are not necessarily the most effective ones. It may be that when we use them, maybe we're not using them appropriately, and we should be using them in a different way in order to try and deal with problems. The problem becomes absolutely critical in the senior population, where the number of prescriptions is in direct correlation to the number of adverse drug effects, the number of problems that we receive with seniors that drives them to the hospital and to the ER. I appreciate you listening.